last month, and I did a frenectomy on her, not to keep this diastema from opening up, but for aesthetic purposes, and allow this papilla to develop better. And I will tell you, that frenectomy, that was one of the hardest ones I've done, because that was like gristle. It was so hard. So, we talked about, she had tonsils and adenoids out shortly after I took out the expander. And some of the absolute indications, by the way, for tonsil and adenoidectomy is tonsillar hyperplasia with sleep apnea, failure to thrive, malignant disease, hemorrhagic tonsillitis, obviously for tonsillectomy. Absolute indications, right here, abnormal dental facial growth. It's an absolute indication. I got this out of the laryngeoscope, and that's from 2002. And I always say, who's better to evaluate facial growth, a pediatric physician or a well-educated orthodontist? I think an orthodontist is better educated to evaluate abnormal dental facial growth. So some of the fundamental objectives of early treatment: normalization of skeletal dysplasias and asymmetries, developing appropriate jaw size, improvement of occlusal function, intervention and termination of recalcitrant habits such as finger and thumb sucking, utilization of growth, and recognition of excessive growth. And early treatment is orthodontic treatment performed at an early age before the establishment of the permanent dentition. Children can exhibit early signs of jaw problems as they grow and develop. An upper or lower jaw that's growing too much or not enough, too wide, too narrow, or asymmetrical can be recognized at an early age. And children over 6 years of age can have these jaw discrepancies and can usually be good candidates for treatment. Remember, dental facial orthopedics cannot be performed on a non-grower. And I think we need to press this with the general dentist sometimes. Instead of getting the child in at age 12, it would be nice to see that child at age 7. Some of the advantages: reduces the impaction of teeth, reduces tooth extractions, reduces the possibility of orthognathic surgery, reduces the incidence of temporomandibular disorders. The dental facial skeleton is obviously more receptive to maxillary expansion at an early age. Growth in some females is completed surprisingly early. And I always find that children around age 7 are more receptive, cooperative, and eager for treatment. And this kind of goes back to Ricketts' point. Ideal time, 5 to 7 years of age. The earlier you treat or unlock the face, the more the face is going to adapt to your treatment concept with normalization of the facial skeleton. If you wait to treat, your concept has to fit the already established face. And remember, children at age 7 have already achieved 75% of the total growth. At age 12, 90% of the total facial growth has been achieved. So here's a patient, 6 years of age, lots of crowding. We got blocked out lateral incisor here, blocked out permanent canines down below, blocked out permanent canine there. Notice the ectopic maxillary first molars. Now, I know many orthodontists would have stopped at this point and decided upon a serial extraction treatment plan, possible Nance appliance or lower lingual holding arch to maintain, or as I say, perpetuate the malocclusion. Here's her scan. And I think the thing that's important to remember on these patients is that they're going to look a lot different as they get older. You can note the lingual position of these second bicuspids on the top. And here's just some cross-sectional images of the arch form, and you can see where this first molar is relative to the lower first. And those second bicuspids are not just lingually positioned, they're lingually angulated too. So with eruption of that first permanent molar, since they're ectopic, you're going to end up blocking out that lateral that bicuspid. Same thing on the other side. So here's her cephalogram taken off the scan. And this too is another patient that has a narrow upper airway. That's just a different view there. With this, we can really see the sinuses as well. So she's skeletal class 3 due to both jaws, crossbite pattern. And down here, she may need extended treatment, surgery may be required, possible excessive lower jaw growth. This is where a growth analysis on this patient is going to be invaluable. And then you can also see that she's a mouth breather, she's got adenoid blockage of the airway. And this just happens to be her growth awareness form. RMODS sends this out for every patient that has a potential lower jaw growth problem. So here's her lateral ceph. Retrusive maxilla, prognathic mandible. Note the retrusive lips and flattened profile. Now remember, a child this age is not supposed to have an adult profile yet. Too many orthodontists don't consider the effects of growth on their patients. And so a patient treated to perfect balance at age 7 or even 12 could become a failed result at age 20 due to lack of understanding or consideration of dental facial growth. So look at this growth forecast. She develops, oops. She develops an underbite. I don't think many people would have suspected her developing an underbite with growth. So I think a lot of guys would think, oh, my 4 bicuspid's coming out, that's going to make a lot of sense. Until you see this. Here's her frontal. You can see the crossbite developing because of the ectopic molars. Very constricted maxilla. So here's my suggested treatment plan. Because of her lower jaw growth, I am going to refer to an ENT, because I want those tonsils out and the adenoids as well. And then bond the upper dentition, level a line, create space for the canines to come in, bond the lower dentition, create space for them, on the canines on the bottom, and then retain with hollies and treat phase 2 after the remaining teeth come in. So here's our patient at age 6. Remember, severe crowding, flattened profile. But just to satisfy those people that want to see 4 bicuspids come out, because they think that's a better treatment plan than mine. Here's the same patient, 28 years later, 4 bicuspids came out, and no regard to growth, no consideration of growth was taken into account for this patient. You'll notice that these arch forms, very tapered in the front, crowding still, dished in profile. Look at the canines, they're actually in crossbite. This patient has jaw joint noises, myofascial pain disorder, tension headaches, very retroclined incisors, you can see there just in that photograph. And I think we were talking earlier about a witch's profile. There you have it. So it's not very pleasing, and I think that poor treatment planning had a factor in this. So we'll go back to the way I wanted to do it. Here's our patient, have bonded the upper arch. Once again, I have open coil springs on the arch form. You'll notice I have them between the laterals and the first bicuspids. I also have RMO locks on the arch wire, and I have springs between the locks and the first molars to help distalize them. So I'm trying to use that entire arch form to help create some space. This gal is 8 years old right now, and I'm still fighting an underbite. So here's our patient 4 months later, 22 months in the treatment, and you'll notice that I finally got on the lower arch form. There's a closer view. One thing I want you to notice how those bicuspids now are moving to the outside just by creating space. So this is a progress scan taken at the same time as the last photos, or 22 months in the treatment. Now you can see we've created space for these canines. They're starting to drop down into place. Remember, this is where we originally started from. And this is where we are today. And this was the patient 8 months later. She's not even 9 yet. You'll notice that she has nearly a full dentition on the upper. We're only missing the second molars at this point, and only have 2 deciduous second molars left. Patient still has a flattened profile. So there's the differences in the arch forms. There's the lower. That's where we started from, and then that's the pan I took at D-band. Now, one thing I want to point out with this case, she experienced some lingual root torque because I wasn't able to expand her with an expansion appliance per se, because all I had was I had to start distalizing first molars. So this might be a case that I'm going to consider some expansion in the future in second phase to get better root angulation. And then same on the other side. That's her lateral ceph, frontal ceph. Now, before phase 1, narrow airway, has some curvature of the spine. After getting her in to see the ENT, notice how the spine straightened up. I don't think they got a complete removal of the adenoid pad. But here's our airway to start with on this patient. It's so far down on this one end that it doesn't even show up other than black. I think there's one red line there and there's another one there. So you can see, get the tonsils and adenoids out, helped with the airway, and it helped with her mouth breathing. She's breathing through the nose. There's her frontal airway analysis. There's the 2 red lines, but it's so dark it doesn't even show up. So if I remove the front of the face, the teeth, you can see how the airway there is quite narrow. And there she is after going in to see the ENT and opening up that airway. I did a progress analysis on her. And what I want you to see is this, is that she's still a severe skeletal class 3. But what doesn't show up is down here, special considerations. It's not talking about excessive lower jaw growth now. And then the other thing is that, according to RMO's airway analysis, airway blockage is probably not caused by the adenoid now. So here's your progress laterals, tracing. And you can see that both jaws kept pace with each other horizontally. Now here's her growth analysis, and she doesn't go into an underbite. 3-dimensional superimpositioning before, and that's after. Notice the increase in width of the maxilla with treatment, even though we didn't do expansion, but we did move the teeth out. And also had some width on the lower jaw increase as well from growth, but we maintained the arch width on the bottom. Three-dimensional superimpositioning. This is always pretty cool. So, a lot of you probably have heard about the paperless office and how great it is.
Emma. Huh? Emma. 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 Emma.
Le trèfle maxifère, vraiment plus large.
All right, that's just to wake everybody up. This next case I'm going to show you is one of those cases that's come into my office where nobody did a clinical exam on the patient and they based all their clinical decisions on this radiograph. And I think this is, and all irreversible treatment recommendations made for this patient were based off of this. And remember all the problems we talked about, panoramic imaging? So the following opinions and treatments all came off of this x-ray. So differential diagnosis, ankylosed right second deciduous molar, supernumerary, odontoma, right-sided maxillary mandibular primary failure to erupt. Now this patient's 6 years of age. So right down here, I'm not even worried about that yet. Number 2, odontoma, supernumerary, they're talking about where this question mark is. And obviously here's the ankylosed right second deciduous molar. So the original treatment plan was general anesthesia, remove the ankylosed baby tooth, also remove the second bicuspid, and then do exploratory surgery to remove the odontoma or supernumerary, in addition to soft tissue exposure of the molars, both upper and lower, and then wait to do treatment after this tooth is erupted in and the rest of the dentition has come in. So she was referred to my office after she'd been in to see the oral surgeon. She'd seen 2, as a matter of fact. And this scan was taken at the request of the oral surgeon, and then he wanted my opinion what to do orthodontically on her, and I said, well, let's do the exam, and we'll go from there. So this is the axial image of our patient. I like axial images because you can see a lot. And in this case, you can see the second bicuspid is lingually positioned and also a little bit forward, but you'll also notice that there is nothing here. There is no odontoma, there's no supernumerary. So for a treatment plan for this patient, what I consider the best one, obviously take a scan and then remove the ankylosed second deciduous molar, allow eruption of the first permanent molar, diagnostic records, do some early interceptive treatment, create space, and then phase 2 treatment later. So we take out the deciduous molar, and now this is 6 months later. You can see that this molar's dropped down and forward. And look what's happened with this second bicuspid. It's actually moved out into the alveolar bone after the removal of that ankylosed tooth. You'll also notice that this tooth is erupting up. We did no soft tissue exposure on that, no soft tissue exposure here. So obviously no need for gingival uncovering. This is her axial image. And I just want you to see how that bicuspid is not only moved buccally, but it's also moved distally a little bit into that space. There's a zoomed in image. So this is photographs taken at the same time as that last scan. Here's our first permanent molar. And you notice down here that the other one hasn't erupted yet. But on the pan you can see that it's moved. So I'm not worried about that. Here's the buccal shot. And you notice that this is a deciduous central incisor that's not for permanent. Severe deep bite. So this patient, obviously class 2 molar, but she's got a skeletal lingual crossbite pattern. That all comes off the frontal analysis. You'll also see that this patient has a tendency for microrhinal dysplasia. You'll notice that the anterior spine is tipped up on the maxilla. Now look at this. She has excessive growth, lower jaw growth, for the next 9 years. Occlusal plane becomes severely rotated counterclockwise with growth. Deep bite deepens. This is not a case, in my opinion, to be extracting permanent teeth on. Early extraction of permanent teeth in a case like this will only deepen the bite, exacerbate the developing skeletal class 3 malocclusion. Change in the occlusal plane is likely associated with a microrhinal dysplasia. We want to resolve the arch length discrepancies early, don't make them worse. And we don't want to wait on this case and treat comprehensively later as previously suggested. That only makes the treatment of this malocclusion more difficult in the long run. So here we are on the frontal. Note the skeletal-lingual crossbite pattern due to the maxilla. Maxillary constriction on the right. Obviously that was related to the ankylosed deciduous molar. So this is my early treatment plan. Band and bond upper archers, level and line, upright and distalize that right first molar and create space for that maxillary second bicuspid. Obviously treat later with phase 2 after the rest of the teeth come in. So here's where we started out. There she is after phase 1 treatment. You'll see that her deep bite is resolved. And you'll note that this first molar is back where it's supposed to be. Now we'll let the rest of the teeth come in and then finalize the occlusion later. I never touched that second bicuspid. It came in on its own because it created space. Here's your pan and inner and deep band. As you go around, you'll note that we're going to have a problem with this second bicuspid. It's rotated about 90 degrees. Remember, that's the original pan we started with. Diagnostic scan to there. I think that extraction on this case of the permanent bicuspid and all the other gingival uncoverings would have had a negative outcome for this patient. And here's her axial image. Zooming in, you see where that bicuspid is. Here's her lateral ceph tracing. Note the significant amount of lower jaw growth that occurred during treatment. You can't get that off of a bad pan. She still has some lower jaw growth left. There's her frontal. You know how that first molar dropped down into place very nicely as far as mesial buccolingually. Comparison of the two arches before and after treatment. There you can see the amount of distalization that we achieved, because that's the first deciduous molar. There it still is right there. You can see how much we moved that molar back. Once again, another shot of improvement in the deep bite. Midlines are on. Now we're just waiting for the teeth to erupt in. I can't say it enough how important I think good records are on patients. And once again, I take records on all transfer cases that come in. This case, remember that we should be designing treatment around the total face rather than narrow objective than just treating the teeth. And I think that if orthodontists practice more along the lines of the principles of bioprogressive treatment, they would avoid the problems I'm going to illustrate with this next case. Once again, it's a case, a perfect example of only partial diagnostic records that were only partially evaluated. It also is a prime example of the benefits of doing a cone beam on all your patients, in my opinion. But I was so frustrated with this case, I wrote it up in Orthotown just because I illustrated the effects of condylar hypoplasia on the developing face, and also the importance of a thorough orthodontic diagnosis and treatment plan. I also talked about airway obstruction in this case, and you'll see why I mentioned these two things, the condylar hypoplasia and the airway, before we go start looking at it. So this case presented exactly as you see here. She had had phase 1 treatment using headgear and fixed appliances. Maxillary first bicuspids have been extracted on this case. And I think you'll see this is why I believe frontal analysis on every patient is vitally important for proper orthodontic diagnosis. Because when you look at her face, you'll see that she's got a facial asymmetry to her right. And the unfortunate thing is, I noted it at the clinical exam, and this was the first time the mother was made aware of it as well. Obviously, the mantra of only taking a frontal when a crossbite or asymmetry is suspected doesn't work because it was missed by this patient by the previously treating clinician. So here's her right buccal view. There's a frontal. No chin. Severely retrognathic. So you can note the difference in the borders of the mandible. And yes, this is the case I was showing earlier about tomos. Once again, severe asymmetry of the lower jaw. She has severe condylar hypoplasia on the right side. There's a marked difference between the two ramuses right now. There's a 14 millimeter difference now, and she's only 12, and she's got about 4 years left to grow. Here's her tomos. Once again, notice a difference in size and shape between the two. Severely flattened over here on the right. This is a coronal shot. Once again, just showing these difference in the size of these jaw joints. Once again, notice the enlargement of the adenoid pad in this patient. Airway is narrow. She's straining here, trying to keep her head forward to breathe because she breathes through her mouth. And I know if you're looking at a lateral, this should have been the first clue that there's a facial asymmetry. But unfortunately, it was probably passed off as poor patient positioning. So here's a 3D rendering of the frontal. You can see that severe asymmetry in her face. There's her frontal ceph. Skeletal lingual crossbite pattern. Now, the reason why the bicuspids were taken out is because they said they didn't have enough room for the canines. Well, if they'd done a frontal analysis, they would have realized that the patient was constricted on the upper. And obviously, taking out the bicuspids on this case has now made it more difficult to treat because this is clearly a surgical case. You're not going to be able to correct a facial asymmetry by taking out some teeth. You're only going to make it worse. And she does have adenoid blockage of the airway. So here's her lateral. Look at the position of those upper incisors now. They should be proclined out to here. But because we took out the bicuspids, put on headgear, dumped everything back, so now it's going to make it more difficult to try and set this case up to do a mandibular bisagittal split osteotomy and move that forward. The other thing too is I don't think you realize the severity of her open bite due to the mandible without looking at these visual norms or just holding up an x-ray because she tips her head forward and up to compensate. Here's her growth forecast. All future growth for the next 4.9 years, all vertical. So, this case is difficult now. Or more difficult, I should say. Here's her frontal. Someone had taken her frontal, they would probably have seen the severe asymmetry, the severe cant to her occlusal plane, severe cant of the lower jaw. And this is all due to that condylar hypoplasia affecting the growth in the right side. And obviously with this patient, she's going to be growing for the next 4 years. So this is only going to get worse until she stops growing. And there's her visual norm. That kind of just puts it in perspective as to how bad it is. So failure to diagnose leads to a poor treatment plan. And in Rachel's case, her diagnosis is condylar hypoplasia, resulting in severe mandibular retrognathia, severe right-sided asymmetry in the skeletal open bite, upper airway obstruction, skeletal lingual crossbite pattern, and then, of course, she's missing her first bicuspids. So, tough case, don't you guys think? So here's what's interesting. I got a letter in the mail about my article. And this was a couple months after the article came out. And remember, this article was on condylar hypoplasia, resulting in a facial asymmetry and the negative effects of upper airway obstruction, further aggravating this patient's orthodontic problems. So this is from an orthodontist that practices somewhere in the Midwest. And now, oh, the other thing too, remember, this was already missed by another orthodontist, so I'm getting this letter from this gentleman, and he makes 2 points. First being about her spinous process of C1 being in contact with the occiput. So it says here, you'll notice as you review the Cbct scan that the spinous process is in contact with the occiput. It's been explained to me as being a potentially dangerous relationship, especially for patients involved in contact sports. The cause of this has been to a fall or accident that causes the occiput to slip forward, downward and forward, because the unique attachment to C1 causes C1 to slip forward with the occiput. Result is a very straight or even kyphotic cervical spine. The patient may or may not experience chronic to acute headaches depending upon age, duration of anatomic discrepancy, attention deficit syndrome, and other syndromes. So, recommendations refer to an osteopath. So, yes, C1 is touching the occiput. However, with class 2 patients with upper airway obstruction, as I pointed out earlier, they extend their necks to open up their airway as they mouth breathe. If you address the upper airway obstruction with adenoidectomy and maxillary expansion, their breathing will improve and the extension of the neck will also improve. Improvement of the extension of the cervical spine should correct this problem. Consequently, referral to an ENT would be a better solution, in my opinion, and that would address the root of the problem. Second point. Discrepancy in the dual levels of the right and left bodies of the mandible. Continues to say this would be due to the glenoid fossas in the temporal bones, one right being higher and more anterior located than the left one being more posterior and lower. Now in my article I published an image of the pan, a 3D rendering of the frontal, a lateral image, supplementary tracings, etc. Panoramic image that I put in the article clearly shows the difference in collar size, shape, and the differences in ramus heights. Remember, this was an article on condylar hypoplasia and its effect on facial asymmetry. And my fellow orthodontist is telling me it's due to something else. So here's her tomos. Once again, condylar hypoplasia, difference in the condyles. If you look at this axial image, you'll see that the glenoid fossas line up with each other parallel, equally distant or positioned anterior posteriorly. Looking at that coronal image, glenoid fossas are vertically parallel with each other, so the facial asymmetry is due to condylar hypoplasia and not the glenoid fossas being out of sync. So here's our diagnostic Ceph. I referred this patient to an ENT for adenoidectomy immediately after these records. And now part of this patient's second phase treatment, I expanded her with a bonded appliance to correct the maxillary transverse constriction, setting her up for future jaw surgery. And this is this patient after just expansion. She went in and saw the ENT after I did the expansion, after I took this scan at the time of RME removal. And what you'll note here is, look at how her airway opened up just with the expansion, Oh, and by the way, C1 is no longer touching the occiput because we corrected the airway problem instead of sending it to an osteopath. So, once again, I feel that if orthodontists followed a systems approach to diagnosis and treatment planning and worked on the total face, I think that their outcomes would be a lot more successful. So, failure to diagnose leads to poor treatment plans, and poor treatment plans result in poor orthodontics. So this is another patient of mine. She's a 7.5-year-old female with severe crowding, potentially impacting maxillary canines. Note the lack of space for the maxillary mandibular lateral incisors here. Here's a zoomed in shot of her upper arch. Very crowded. And there's her lower arch. There's a frontal view. So here's her scan. And from the panoramic image, you'll note that the left canine is already erupting mesially over the left maxillary lateral incisor. Maxillary left first molar is ectopically erupting. And extraction of deciduous canines in a case like this is not going to alleviate the crowding. Because I know a lot of people will be talking about taking out deciduous canines. But taking out deciduous canines was based upon a study from 1988. And in that case study, or in research, the patients were of average age of 11.4 years of age, not 7 like this patient. And the canines, when they took them out, it's because the maxillary canines were ectopically erupting and not impacted. So here's a 3-dimensional volume rendering of the panoramic image, and you'll note that the canine is right on top of that lateral root, and the right side doesn't look much better. This is what's kind of cool with Cbct. You can rotate these images and you can see the position of these teeth even clearer. Here's our lateral cephalometric image. And once again, it's important to evaluate everything in these Cbct images. Once again, note she has an enlarged adenoid pad. Here's her frontal. And there's a 3-dimensional volume rendering of that frontal, showing the position of those teeth a little bit clearer. So here's her lateral cephalometric image, tracing. And skeletally she's 8, even though she's only 7.3 at the time, chronologically. And I think the thing is, why I like the visual norm so much is the fact that if you look at this case,